of Veterans Affairs. We appreciate the effort of VA's dedicated staff to provide medical care, benefits, and support to veterans, their families, and their communities every day. We're here today to discuss the Department of Veterans Affairs fiscal years 2025 budget and 2026 advance appropriations requests. This committee takes very seriously the obligation to make sure we provide for the men and women who have fought and sacrificed to keep our country safe and ensure they have the medical care and benefits they've earned. This budget strives to do just that and requests a mandatory appropriation of over $210 billion and a discretionary appropriation of $129 billion in FY25. VA also has access to over $24 billion from the Toxic Exposures Fund that was provided in the Fiscal Responsibility Act. These resources are extremely important in providing funding to carry out the expansion of medical care and benefits in the PACT Act. Without these resources, VA simply would not be able to keep up with the processing of new claims or expediting health care benefits to veterans who are exposed to toxins and environmental hazards. The budget also requests advance appropriations for FY26, including $131 billion in medical care discretionary accounts, $23 billion in mandatory resources for medical care funded by the TEF, and $222 billion in mandatory resources for veterans benefits programs. Despite this robust request, I am concerned about medical care levels in this budget. The discretionary funding request for medical care is lower than the FY23 enacted level, and when including mandatory medical care spending, this still represents a cut from FY24. As I stated earlier, this committee has an obligation to provide for the men and women who protect this country, and I'll need your commitment that this budget does just that. VA is seeing a higher reliance on the Department for Medical Care and greater utilization of benefits and services than prior years, in part due to the success of the PACT Act. Veterans are relying on the VA for more care today than ever before, but the FRA top line is forcing cuts across government. So the VA must do more with less. We know this is impacting staffing level at medical facilities and that there are programs that will not be expanded as a result of these levels. There are a few initiatives within the budget request that I'd like to highlight. The budget continues to request robust funding for its telehealth program, with an estimated $6.4 billion for FY25. However, even with expanded hiring and telehealth capacity, veterans in rural areas often struggle to access health care, including due to challenges with transportation and lack of internet access. I continue to encourage the VA to look for innovative and cost-effective ways to close these access gaps. At the end of last year, VA signed an updated agreement with the Indian Health Services. The new agreement allows VA to reimburse IHS for additional health care services, including long-term care, home health services, and durable medical equipment. I encourage VA to continue establishing agreements with individual tribal health programs to further eliminate barriers to care for American Indian and Native Alaskans who've served their country. Women are the fastest growing demographic entering the military and now represent nearly 20% of service members. The women veteran population is also the fastest growing demographic within the VA. This population is only anticipated to grow, and caring for these veterans should be an area of bipartisan support. This budget requests a historic $13.7 billion for women veterans health care, including $1.1 billion in gender-specific care. I hope we can include that level of funding in this year's appropriations bill. The Electronic Health Record Modernization Program continues to be in a strategic pause to assess and address issues discovered during the first 5 site deployments. VA recently deployed the new system to the Lavelle Federal Health Care Center in Chicago. However, it's still too early to determine if this deployment was a success. The budget request shows a substantial cut to the EHR program, and the request assumes no new deployments will happen this year. While patient safety is our number one priority, VA needs to commit to getting this program back on track to deliver a safe and secure health record. Last year, VA surpassed its goal of housing 38,000 homeless veterans. This is significant, but there is still more to be done. The most recent point-in-time count numbers show a 7.4 increase over 2022 in veterans experiencing homelessness. The budget requests $3.2 billion to continue to ensure VA has the resources to secure housing and case management support for this veteran population. Secretary, it's clear that much is expected from the department. Providing health care requires facilities, technology, and clinicians, and quickly providing benefits requires staff and technology support. For the department to succeed in these efforts, you must be resourced appropriately. I look forward to working together to provide veterans with the services and benefits they've earned and deserve. Thank you. And now I'll turn it over to Ranking Member Bozeman.
Thank you, Madam Chair, and Mr. Secretary, it's good to have you here today. Thank you for coming to discuss VA's fiscal year 25 and 26 budget request. The budget request of $369.2 billion in fiscal year 2020-25 for the Department of Veterans Affairs, including medical care collections, the Transformation Fund, the Toxic Exposure Funds, representing a 9.8% increase over the fiscal year 24 enacted levels. This includes $129.1 billion in discretionary funds, a $5.7 billion or 4.2% decrease from fiscal year 2024. The request includes $235 billion in mandatory funds, a $41.8 billion or 21.6% increase over fiscal year 2024. Within this amount of $24.5 billion in the TEF, $4.2 billion increase over fiscal year 2024. The budget also requests a total of $131.5 billion in medical care advance appropriations for fiscal year 2026, $118.9 billion more than the fiscal year 2025 advance appropriation, and $22.8 billion in advance for the TEF. Finally, the request includes $222 billion in advance funding for veterans benefits. Mr. Secretary, I think we could agree that the budget request can reasonably be characterized as tight, and that's not your fault. It's just the circumstances that we're in. In my more than 20 years working on veterans issues in both the House and the Senate, I can't recall a single year when the budget request for veterans health care went down. I recognize that VA has more funding streams than ever before, including the TEF, but nevertheless, this request stands as an outlier. In recent years, I've asked you about the amount of risk VA takes in crafting its community care request, but this year I will want to know more about the level of risk VA is taking across its whole enterprise. In your testimony, you refer to fiscal year 2025 planned obligations, which will grow by more than 5%, even though the base request is lower than last year. I want to hear from you about what risk this may open the VA up to. I understand that this is not about you. This, again, we're just in a situation where money's tight. The PACT Act has certainly been a dramatic change for veterans, and I also think VA has a very good story to tell about its implementation, the new veterans enrolling, and the number of PACT Act-related claims received and processed. Again, I know that you and your staff throughout the VA have worked so hard to make that a success. It also gave VA new tools to recruit and retain its workforce, and I look forward to hearing about your plans to ensure you have the right people in the right places to take care of our veterans. I also want to note that it's been a little more than a year since you announced the reset of the electronic medical records program. As this reset continues, I hope to hear more about the timeline to bring the deployed sites up to standard when we can expect deployments to resume. DoD stumbled out of the gate in its efforts, but after a pause, it successfully completed deployments through the country and abroad. I hope the VA has learned from that and we'll be able to get this program moving forward again soon. With well more than $11 billion of taxpayer money invested, it's time to start seeing a return. In addition to updates on those big picture items, we also look forward to hearing details about the Department's request for mental health services, including efforts to prevent veteran suicide, initiatives to prevent veterans homelessness, resources dedicated to care for women veterans, and efforts to improve care for our rural veterans. We look forward to discussing these other issues, and again, very much appreciate you being here. Thank you, Madam Chair.
Thank you, Ranking Member. Mr. Secretary, we'll now proceed with your opening statement. You have 5 minutes.
Madam Chair, thank you very much. Congratulations on the new assignment. Senator Bozeman, other members of the committee, thank you, Senator Baldwin, for the opportunity to be here today. I'm willing to just put my prepared remarks into the record and get straight to your questions if you all are amenable to that. So I'm happy to go straight to questions.
I thank you. I really appreciate that. So we'll start with a round of 5-minute questions of our panel. I ask all my colleagues to keep track of your clock and stay within those 5 minutes. I'll start with the first round of questions. Secretary, your models project that utilization of VA healthcare will rise, but the discretionary funding request for VA healthcare is below the levels from FY23, and even including mandatory health care funding, it's $4 billion below FY24. So what are the current spend rates for the medical care accounts in FY24? And based on these trends, do you expect to be on target for FY25?
Yeah, thanks so much. We anticipate spending about $140 billion on healthcare out of that account in FY24. All in, FY25 in the budget is $150 billion when you count our various funding streams, medical care collections, carryover, importantly, about $12.7 billion in carryover. And then, as you said, the Toxic Exposure Fund, which is an increase of about 7% in total healthcare spending. So there's no doubt, as we've talked about a number of times in the course of the last week, that money is tight, and that is a function of the budget agreement. But we think that we have the money that we need here, and we have, most importantly, the people that we need to implement this increased access to care.
And Secretary, at these levels, how can you make sure that you're able to pay for the care that veterans received in the community while also investing to ensure that the VA is an available option for veterans?
Really good question, and this is one that we spend a lot of time worrying about. The budget takes a lot of unique steps this year as it relates to community care. Perhaps we've already notified to you all that we are taking the $1.9 billion in rescission from other than community care accounts in the VA. We also ask that we reprogram in the advance $7 billion into community care. That reflects what is a very robust set of referrals over the second half of FY23, but also reflects what has been basically 15% year-on-year growth going back to the enactment of the Mission Act. This is higher than CBO would have anticipated, and that's one of the reasons that we make these big moves that we make here. Notwithstanding those moves, we think that because of the hiring year that we have had and our ability to continue to strategically hire where we need it, that we can also meet our demands for care in the direct care system. We do not ask for a second bite on the advance, but if we find out over the course of these next several months that because of our outreach efforts, we have 550 outreach events this year, because of our outreach events, that we're getting more veterans enrolled. Just since March 5th, we've had 12,500 veterans uniquely from the PACT Act cohort having enrolled in VA. If we see that continued kind of growth, my hunch is we may be coming back to you after working with OMB to ask for a second bite if we need to. But again, margins are tight. We feel like we have the investments we need. If we begin to run into problems, we'll definitely come to the committee. Lastly, we are tracking this very, very closely. We've implemented a series of budget execution tools. It is our intention to share those tools with this committee, with your team. We're working through all that paperwork on our end of the street before we do that. So you all, as a team, will be able to follow along closely with us on the execution of those goals.
Thank you, Secretary. The FY25 budget request, as I mentioned in my opening remarks, includes a lower level of spending for rural health programs than was appropriated for FY24. So first, can you assure me that the VA will direct the full amount of funding towards rural health programs in 24?
You have my assurance.
Thank you. And the second question would be, what are innovative initiatives that you're developing to increase access for rural veterans to address the fact that there is a proposed reduction in spending for FY25?
Yeah, well, thanks very much. We are, among the more innovative things we're doing right now is we're enhancing our cooperation with the Department of Defense and over the course of the last 2 months with the Department of Agriculture to increase access points in rural settings so we can get care closer to veterans. That's one innovative solution. Second, things like access to cancer treatment. We announced a new program last week, Close to Me, where we forward deploy VA professionals to CBOCs closer to veterans so that they can get their cancer treatments closer to their homes rather than having to drive all the way to Phoenix, for example. They'll be able to go to their local CBOC, supported by their family, not having to drive those longer distances. We can do that within the confines of our budget because cancer treatment drugs are 30% cheaper for VA than they are for our private sector partners. Third, we are forward deploying VA professionals, I saw this in the Upper Peninsula of Michigan, to community hospitals, including federally designated health clinics, so that we can identify vets who are coming in to treatment, not enrolled with VA. We can then get them enrolled and get them support in those facilities. Ultimately, that has cost over the life of the program for VA, but no cost up front. Lastly, the Office of Rural Health has been basically flat at $337 million for the last 3-4 years for the simple reason that we finance our clinical resource hubs principally through the Office of Rural Health. That means we're going to continue to rely on telehealth, as you said in your opening statement. Then the rest of the investments out of that office are for enterprise-wide innovations. Among those that have innovations that have come from that office that can be funded at that $337 million effort are home-based primary care. This is where we are sending providers into rural settings like Maine and Arizona and Montana and Wisconsin and Arkansas, so that we are taking the care to the veterans, right? So that's the idea. Not that we continue to fund those through the rural care account, but the rural healthcare office, but rather we then transfer those to being funded through the standard medical care account.
Thank you, Secretary. Senator Collins, you're recognized.
Thank you very much, Madam Chair. And again, I thank the Vice Chair for his graciousness in allowing me to precede him. Mr. Secretary, let me start with two facts. One is that Maine has one of the highest percentages based on population in the country of veterans. That's something I'm very proud of. Mainers have always stepped forward to serve. Amen. Second, Maine is the oldest state in the nation by median age. So when you combine those two factors, you can easily see why our state veterans' homes are so important. In fact, both of my parents had the benefit of compassionate care at our state's veterans' homes at the end of their lives. In 2022, however, despite the strong demand for these services, Maine considered closing two of its veterans' homes, one in Machias and one in my hometown of Caribou. Fortunately, that was averted, but it would have caused tremendous hardship to veterans and their families. And Maine is not unique in this regard. A recent report indicates that other veterans' homes across the country have notified the VA of potential closures. 15 have reduced their bed capacity. Another 4 have already closed permanently. The VA raised its per diem rates in 2023, but frankly, that increase has not kept pace with rising medical costs. And the veterans' homes in Maine, as is true across the country, are struggling financially. What is the VA doing to support financially troubled state veterans' homes, and what more can be done at the federal level to prevent closures or reductions in beds?
Yeah, Senator, thank you very much for the question, and I couldn't agree more strongly with you about the importance of state veterans' homes. That's why we bias in VA funding streams for bigger investments in the state-run veterans homes than we do in the commercially run veterans homes and long-term care facilities. Among the things that we are doing, obviously, is up to 65% of the cost of the facility construction, remodeling grants, importantly, nurse recruitment grants, and I'll come back to that in a second, medical sharing arrangements with considerable cost sharings when we can get our personnel into those facilities to care for vets, and then continued clinical care education. Notwithstanding that, and as you pointed out, the per diem has increased 7% in '23, and again another 7% in '24, higher than our increases for other similarly situated programs. Nevertheless, I agree with you that there are big challenges out there, especially in two areas. One of the reasons we're hearing from other states, not in Maine, but from other states that they're closing, is they don't have the staff. Because the veterans that they're getting are requiring more complex care. So, greater funding for staff who can provide more complex care for those veterans is important, and this is something that we'll be more than happy to work with you in Maine on and work with the committee on. Secondly, the cost of pharmaceuticals for those veterans who end up in state-run veterans homes. They, by tradition, the states take on the cost of those pharmaceutical treatment patterns. They also don't have access to our more price competitive formularies. So we'd like to also work with you on that to figure out how is it that we address these significant costs associated with pharmaceutical treatments, because our veterans are living longer with more complex healthcare systems. So those are two areas where we'd like to try to enhance our support to states like Maine. One, how do we make sure that we can afford the staff that we need for the complex care they get? Two, how can we ensure that we are not just passing on a very unmanageable pharmaceutical treatment regimen that the states can't afford, but the veterans need?
Thank you. I only have 19 seconds left, but just to put on the record, there's also a problem with transporting veterans from rural areas to the one VA hospital that we have in the state of Maine. And I hope that that's something that we can also work together on.
We count on that, and we have a legislative proposal on that. I've been studying up on this since you and I discussed, so we have some ideas on that.
Thank
We'd like
you.
to work with you on those.
Terrific. Thanks so much.
Thank you, Vice Chair Collins. I recognize Senator Baldwin.
Thank you, Madam Chair. Mr. Secretary, there has been a steady and significant decline in the number of veterans being prescribed opioids for pain management since 2014. The implementation of the Comprehensive Addiction and Recovery Act in July of 2016, which included the Jason Simkoski Memorial and Promise Act, has contributed to this trend.
Very much.
From a nationwide high of more than 878,000 veterans prescribed opioids in the last quarter of 2013, the number decreased to fewer than 300,000 at the beginning of this year. That 67% decline in prescription rates over the last decade is extraordinary and is really a testament to the progress we can achieve if we work diligently and resource the VA appropriately. This decrease in opioid prescription rates does not mean that the VA isn't treating pain. Rather, it means that the VA is treating pain responsibly. For example, the Toma VA Medical Center spearheaded the Pain University initiative to achieve improved pain management through comprehensive solutions without the use of opioids. So, Mr. Secretary, how else can Congress enable the VA to provide these integrative health options for our veterans? And what does this committee need to do to support and continue the efforts to responsibly manage pain and that pain care for our veterans?
Yeah, Senator, thanks very much. I think the tools that you pointed out are really important, and I thank you for making sure that we got them, and I thank Marv Simkoski and the Simkoski family for the dedication that they've manifest since Jason's death. We asked for $254 million for pain management and opioid safety on prescription drug monitoring in the budget. We think that's an appropriate and prudent investment. That's the first thing we would ask. Secondly, we need to continue to staff up. We're not yet at 100% of facilities with pain management teams. That's required in your law. We're north of 90%, but we're not yet at 100%. So continued investment to allow us to build out those pain management teams. Third, the whole health initiative allows us, TOMA is also a flagship effort here that allows us to deploy new clinically proven pain management techniques that are non-pharmacy based. So those range from acupuncture, battlefield acupuncture, yoga, meditation. All of these things are really important to making sure that we can manage holistically that veteran's pain. We're very proud of the progress we've made on opioid prescription. That's directly a result of your law, of investments in alternatives, and of accountability for those alternatives. I think this budget gets us a long way to continuing that process.
Great. Mr. Secretary, I've heard you say, and I know you feel this deeply, even one veteran suicide is too many. And I know you are working to reduce this troubling epidemic. I share your concerns, and I was proud to lead the bipartisan legislation that transitioned the VA crisis line to the National Suicide Prevention Hotline 988 number. During the first year in operation, the Veterans Crisis Line fielded nearly 1 million contacts. The implementation of this line has not been without difficulty, and it will take commitment to oversight to get this right for our veterans. So can you please provide both your assessment of the contribution the Veterans Crisis Line has made in addressing suicide among veterans, and inform the committee of what additional resources would help rectify some of the problems and issues with the crisis line that have been identified?
Yeah, thanks so much. I'm very proud of our Veteran Crisis Line team. I've met with our operators there many times. Their work is proven time and again to be timely and effective. It's not to say that's without faults. We've had really tough, hard-hitting IG investigations on that relate to training. That's on us. We have the funding for training. We have the funding for staffing. There is an issue on the continued funding of the crisis line itself, the 988. This is not an issue for us, but this is for VA. But this is an issue at the states. The stand-up of the line envisioned a federal role at the start, handing off to the states making the investments thereafter. Remember, the way it works for us is, as a veteran, you call 988, then you press 1. At that point, you exit the general crisis line, and then you're into the VA-managed veteran crisis line. Notwithstanding the substantial increase in number of calls in the first year, time to answer shrunk, abandonment rate shrunk, and follow-up assessments with the veterans in terms of survey results demonstrate increased satisfaction. So we think that the execution is going well. That's not to say, again, it's without faults. You'll recall that many of you held us publicly accountable for an IG report out of one of our Veteran Crisis Line teams, and we're taking that very, very seriously. But we have the funding we need. We have the training capacity that we need. I really hope that we can ensure continuity of the overall effort through funding from the states. But VA, thanks to your all's generosity, is in a very good spot to continue our part of that Veteran Crisis Line. I'd say one last thing. We also began executing a year ago the Compact Act. So if a veteran doesn't want to just call 988 and press 1, that veteran can go into a hospital.
Right.
Any hospital, irrespective of enrollment status with VA, and get care today. And we will pay for that. Again, there's growing pains in that program. It's not perfect, but 47,000, almost 48,000 vets took advantage of it in the first year. We think it's a really important program. That's reflected in these community care numbers too, by the way.
Thank you, Mr. Secretary.
Ranking Member Bozeman.
Thank you, Madam Chair. And again, thank you, Mr. Secretary, for being here. As I said earlier, I've really had the opportunity in the House and now in the Senate
Yes.
to be on the VA committee for quite a while. We do have a situation where we have a decrease in veterans' health care. So I guess the question is, and I've got all the figures, and we don't need to go through that. You know those, you and your staff know those better than anybody. But the question is, how much risk are we taking, assuming with this budget, and what opinions, how much risk we're taking, and then what options we have if those assumptions aren't correct?
Yeah.
What do we do?
Yeah. Well, I think the highest variability item in this multivariate equation here is community care. And I think it's generous to call it variable because it's variable in one direction, and that's
Right.
up. And there's a lot of reasons for that, and frankly, we don't know them all yet, and we're looking at that. So, if there is elevated risk, it would be in there. But our options to manage that are our ability to come back to you to ask for some authority to transfer among different accounts in the medical care account, so that we're not taking substantial risk on the provision of care there. At some point, we will take risk on maintenance of the personnel that we need at VA to carry out the full suite of care that veterans expect. Because you can't have a high variability purchase care program that's increasing every year and maintain a high cost direct care system with big fixed costs for personnel. That's the trade-off that we're going to confront at some point. I think we begin to confront it in this budget, which is why we, I think prudently, especially informed by last year's very productive hiring year, make some decisions to downsize VHA and VBA, by the way, as I've promised you we would do, by the end of '25. But frankly, when you consider those numbers, 10,000 over a denominator of about 400,000 employees, that's not much greater than traditional attrition at VHA. Now, we're a little under traditional attrition right now. Why? Well, because you were you're so generous to us with funding for staffing increases, pay increases, and things like the critical skills incentive. So this might be a little bit harder, might be slightly more risk because retention is up, quit rates are down, but I consider that a high-class problem, not a risky problem.
Right. One thing I'd like to get on the table, just being out and about,
Yeah.
visiting in various facilities,
Yes.
again, just talking to providers. As more PACT Act claims are processed, many veterans will see an increase in their disability rating. So you can have people at 70%
Go to
because
100.
of the PACT Act go to 100%.
Yeah.
And then the problem then is, as a result, a number of them will become newly eligible for things like dental benefits.
Yes.
Dental in particular.
Yeah.
Which I hadn't heard a lot about. And I guess the question is, this is rising. The number of veterans eligible prior to the PACT Act grew by more than 8% a year. Last year it grew by nearly 12%. Given that VA dental clinics operate at near capacity, this growth will likely be addressed by community care.
Yeah.
So I want to put that on the table and see if you have a response. But
Yep.
there's just I think a number of things, and this is probably the biggest one of not unintended consequences, but consequences that are out there that we need to take care of. It's a good thing for veterans,
Yeah.
but that's going to cost some money.
Yeah, I think you're right that this is a consequence of PACT. I think, frankly, it's among the things that veterans are most excited about because of PACT, because there's so much, you know this better than I do, so much demand for dental.
Right.
And so many people who wish they qualified. So just to give you some numbers, 17% more 100% service-connected veterans today than before the PACT Act was signed.
Right,
It's a substantial number.
right.
If you consider FY23, we had 690,000 eligible veterans for dental. 567,000 got that care 100% on site. 123,000 got that in the community, right? Our dental staff increase in 23 was about 4.8%. So they saw a similar bump. So we should be able to continue to grow with dental this year. But the big number out there, the big bogey here is 2.78 million eligible veterans for dental by 2028, up from 690,000 in 23. So our budget gets us going on that process.
Good.
But you're right that there's this transition period.
Right.
Until we have dentists, hygienists, and chairs in our facilities, there is this transition period where we're going to be relying on the community.
Right. Great opportunity for veterans. The only thing that would be bad is if we couldn't, once we've said
Can't let 'em
benefit
down.
is there.
Can't let 'em down.
Exactly.
Yeah.
Thank you, Madam Chair.
Thank you. Senator Tester.
Yeah, thank you, Madam Chair and Ranking Member. Appreciate you having this hearing, and it's always good to see you, Secretary McDonough.
Sure.
Did you sleep here last night, or no?
I didn't sleep much last night.
That's good. The only thing I would add to the dental care thing is I think for the veterans long term, this could actually help reduce healthcare costs moving forward, because you got dental problems, you got health problems.
Heart problems,
Yeah,
mental health
exactly.
problems. There's just no
Exactly.
question about it.
Every day I get visited by folks and they bring up issues that potentially impact veterans. You know how many Native Americans serve, highest than any other minority. And I met with some urban Native Americans today that they told me two things that I want to ask you about.
Yep.
The first thing they said is that the VA uses us, the urban Indian healthcare, they use us, but the reimbursement is less than adequate. That's number one. I just want you to respond to that. And the second thing they said is that they use us because, and I'll give you the community if you want, because the community where the VA CBOC is not fully staffed with doctors, so they have to have us.
Yeah.
You guys put a freeze on, I get it. You hired 14,000 new nurses. It's time to take a breath, take a look, see what you got, and then move forward. I don't disagree with that. But the question becomes, we're talking about community care. We're talking about VA care. If we don't have proper staffing, as Shane Lerman pointed out yesterday from the DAV, it forces more folks into the community.
No doubt
Those
about it.
inflated prices go up. That's one question. The other question is IHS treated differently when it comes to the Tri-West, in my case,
Yeah.
in Montana?
Yeah, thanks so much. So the UIOs I spent time with them day before yesterday. They're really great partners. No secretary had ever been to a UIO, but I went with Senator Moran in Wichita on my first trip right after I left Montana. We want our Native veterans to get the care that's culturally competent for them, where they need it, when they need it.
Right.
That means at a VA facility, at a UIO, or at an IHS facility, or by the way, in the community through the community care program. And you know this better than I do, the number of Native veterans who are living in urban settings away from their families and their tribes is extraordinary. So we negotiated a new reimbursement agreement with the UIOs, but I challenged them when I was with them on Tuesday. We've had 0 requests against the new arrangement
Okay.
since I went to the facilities in 2021. We got to do a better job, right? Now, we also have a new reimbursement arrangement with IHS. And Rosalind So and I are, I think, working really aggressively on that. The chairwoman mentioned this in her opening remarks. We have a new reimbursement arrangement with them. We're finalizing that plan. It's with IHS now. I'm really excited about the opportunity, not only for veterans to get care there, but we've also committed to our Tribal Advisory Committee, which you put into law, that we will begin having CMP exams at IHS facilities, closer to veterans. But again, we have the tools there. We just have to figure out why are people not taking advantage of them.
Okay. And then talk to me a little bit about staffing and the impacts that has on community care, which you say
Yep.
is doing nothing but going up.
Yep. It's whatever, a Gordian knot. It's a really tough question because you got the chicken and the egg. At what point are we not providing care
Yep.
in-house because we don't have people? This is what you've challenged me to do since I
Yep.
got here. And at what point are we providing care in the community because it's easier to do? That's why we've made the very aggressive effort over the last 3 years to staff up as aggressively as we did. 1, 2, that's why we ran an access sprint to test the proposition. Are these new clinicians seeing veterans?
Yep.
And we proved that in 25,000 cases, they are. But we have to get better on productivity. And then we have to show every time a veteran has a choice, we make a referral for that veteran to go to the community. We say, hey, this is where you qualify in the community. You should do that if you want. But we'd like you to stay with us, and here are your options there.
But they can't stay with you unless they got the staff.
Correct, which is why we have this period under the access standard,
Yep.
the access sprint that we just showed,
Yep.
that we're seeing 11% more clinical visits
Yeah.
in that period.
Yep.
We have to extend that
Yep.
and keep those vets in the system. And by the way, we're going to keep adding vets. So as we do that, if we need more money, we'll come back and ask for that in a second bite. But I want to do that because there's more vets demanding more access, not because we can't manage our workforce.
Here's the point I want to make, and I'm going to give it up here in a
Yeah.
second. The point is as you go into this hiring freeze, don't forget to look at the hospitals
Yes.
that are short on PAs, on docs, on RNs, on all the above. Because if we don't do that, you can't expect community care to even begin to level off. It's
with
going to continue to go through. So hopefully your VISN directors and the director in VA Montana, which by the way is doing pretty damn good, will take a look and say, hey, we'll put pressure on you guys to get more docs in here because we need them. Otherwise, the community care issue is going to continue to grow and grow and grow with
not
the
agree
emergency
more.
care and everything else. Thank you, Madam Chair.
Couldn't agree more.
Thank you, Senator Tester. Senator Murkowski.
Thank you, Madam Chair. Mr. Secretary, good to see you. Thank
you,
you
ma'am.
for your visit to Alaska. You know you are welcome anytime. The snow is melting and the weather's getting pretty good. One of the things that I wanted to raise again with you is the Palmer Pioneer Veterans Home. We made it through the winter without losing
Yeah.
losing that roof. But
Right.
as you know, this is something that we've been watching for a long time. This is something where just last March, we got the VA Engineering Office to issue this memo stating that the threat of a roof collapse does constitute a life safety
Yep.
issue. It's been reclassified. That's great. It now goes to what I understand
list.
is top of the sub-priority group. So we made it through the winter, and we had a lot of snow. But I am not certain that this roof is safe moving forward. And so the sooner, the faster we can attend to this. I would just put that before you in terms of prioritization.
You got the good news is our engineers have come to the same conclusion you have. So it does get to the top of the list for us, but I'll stay on top of this and make sure that we stay in close touch with you.
Thank you. I appreciate that, and I know all of our veterans there at the Palmer Home appreciate it. I had a meeting about a month ago with a group in Fairbanks who have been working this Fairbanks Veterans Cemetery for a long time,
Yes.
probably about 20 years now. And I appreciate that the VA has placed the vet cemetery there as a high priority among the projects to establish new cemeteries.
Yes.
But the way the list is stacked, as you well know, it puts the expansion of existing facilities. There are multiples ahead of any of the efforts to bring on a new facility. I think you've heard the benefits that a veterans cemetery in this region would be. It would serve about 65% of the state's veteran population. We have one small tribal cemetery down in Metlakatla. We have a second national cemetery that serves southeast in Sitka. We've got the one at J-Bear, but that's difficult to access.
Yeah.
So this is a very significant region of the state with a very significant population of our veterans. And again, they have been working aggressively on this. I'm hoping that the committee is going to be able to fully fund this account for FY25 and in future years. But what we're trying to do is to figure out if there's a way that there can't be, maybe it's splitting the grant funding so that you have a certain percent for expansion projects and reserve a certain percent for new construction. Because as we're looking at this list, it's going to be years and years
Surely at the current
before
level, yeah.
a new construction of a cemetery is going to be allowed to proceed. So maybe you have a better idea of a timeline that we might be able to report back to folks. But I'd like you to take a look at that list. We're going to try to do our best. I'm certainly going to put my shoulder into it on the committee here to see if we can't get that number up.
Yeah.
But even if we get it up, it's going to be a long time before you get to any new construction.
Yeah, so I've asked our team to look at this this particular Fairbanks option in the context of our overall strategic goal to have, 95% of veterans within 75 miles of a hospital.
And you
of a
definitely
cemetery.
need this one.
That's what I mean. So I
Yeah.
think this feels like it probably analytically can that may be important. So I've asked for that review.
Yeah, we're 350 miles away from the
Exactly.
closest one.
Exactly. So I've asked for that review. We'll stay in close touch with you and with the whole delegation on this.
Good, I
And we'll make sure
appreciate
that the importance of this is coming through very strongly. We
Good.
got it.
Thank you. And I'm running close on time, but I'm curious about where we are with the claims backlog and the claims inventory and the backlog, because I'm told that following the PACT Act, we've seen that increase dramatically. We've also seen the claims accuracy backlog. I'm told that the accuracy rate has dropped to just over 83%, the lowest it's been in the last 10 years. I don't know if this is directly related to the claims backlog, what we're seeing with the increase, but know that this is an issue that our veterans are raising in Alaska. I'm sure that they are in other states as well. So I don't know if you can give us an update on
Definitely.
that.
Thanks for the question. Backlog as of this morning was just over 300,000 claims.
How does that
Inventory,
stack?
yeah, inventory is about 930,000 claims. So we're at, I think, if I remember that right, but I'll get you the specific number by close of business today. But we're at about a 31% backlog rating. Of the overall inventory, about 31% of the claims are backlogged. That's generally in the zone of what we have considered healthy for backlog, because we're not going to rush to get a no to a veteran
Right.
if more development will get us to yes. That's the first thing. Second, we did anticipate, by the way, we've been able to manage this. This is kind of much on the low end of what we anticipated and frankly what our model told us the backlog would be by now. And it could be, by the way, that we're on the downside of the backlog, but it's too soon to definitively state that. The main input there is people, and we've basically increased the VBA workforce by about 25% in the last 3 years, anticipating this influx of claims. So
Has that impacted the accuracy because you're bringing new people on?
Correct. So that's the last point, and this is where I'm not sure where 83% comes. I just got an update yesterday. We're at 93%. But there, frankly, we have a dispute with our IG too about he scores our accuracy differently. So I don't want to over-index the number, but there is quality concerns, which we anticipated because of so many new people and because of the training requirements. So we have throughout the course of the summer a quality stand down, which will increase enhanced training and an update of the training program to review these quality questions. Because again, this is traditional seesaw in VA. We worry about the backlog when it grows, so we over-index on the backlog number. So then all of a sudden quality comes down. So we have to kind of toggle back and forth between these two things. We've anticipated this. I hope the stand down that we're going to undertake over the course of this summer addresses that. And again, that's a training issue, and then that's an oversight and management issue. And again, because we're seeing the same thing in VBA, enhanced retention of our personnel, I feel pretty good about our ability to address that.
Thank you for your attention to
Yeah.
this. Thank you, Mr. Secretary. Thank you, Madam Chair.
Thank you. Senator Peters?
Thank you, Madam Chair. Secretary McDonough, it's good to see you again.
Sure.
Thank you for being here.
Yep.
As service members transition into civilian life, it's absolutely critical that they have the tools and the job training that they need to be successful in that transition. In 2020, my bipartisan bill, the Support for Veterans in Effective Apprenticeships Act, was signed into law. What the law did is it increases veterans' access to financial assistance they can use in connection with an apprenticeship program, and requires apprenticeships to factor in the skills, the training, and the experiences they gain through military service, which is often extensive, and helps the veteran get placed in those apprenticeships. But the fact remains that for veterans to use their GI Bill benefits on these programs, they have to actually be aware of apprenticeships in the first place and how those GI funds can be used to help them get that training to transition. This committee, as part of the FY23 VA funding legislation, directed the VA to take additional actions to promote awareness and increased utilization of apprenticeships among veterans. So my question for you, sir, is what is the VA doing to ensure veterans are aware of the opportunity to use GI Bill benefits on apprenticeship programs, and how does your FY25 budget request support further outreach to these individuals?
Yeah. Both education, the general education program at VBA, and the VRNE, the Veteran Readiness and Employment programming at VBA, because of the committee's requirements, have enhanced and have specific targets to increase enhancement of communication around apprenticeship options. So the budget fully funds those because it fully funds our programming for both. And we will begin to see data on the uptake of that, and we'll accumulate that data and share that with you over the course of the coming year.
Great, I appreciate that. I also want to ask you a couple of questions related to VA Inspector General investigations. First, you and I have spoken repeatedly about my concerns regarding a case of Ian Fishbeck.
Yes.
You know, Ian is a native Michigander who tragically passed away in 2021 following a decline in his mental health as he and his family and friends worked very hard to try to gain admittance to a VA medical facility. I was pleased when the VA opened an Inspector General investigation into his case last summer following our conversations. But my question for you, sir, is I know the investigation is ongoing.
Yes.
But I want to get your commitment today that once that investigation concludes, you will implement the IG recommendations across the VA as you become aware of them.
Yeah, Ian Fishbeck was also a national hero. One, two, you have my commitment to implement those recommendations. Three, I've been in close touch with the IG on this. I have every expectation that he's wrapping up his work and that will be public soon. And I think the IG does really important work, really good work. My guess is it's going to be really tough for us, but that's the most important stuff that we got to get right, and we will.
Well, I appreciate your commitment and your your attention to this from the get-go. I also want to touch on the Detroit VA issue. Back in 2022, Senator Stabenow and I were alarmed to learn about a crisis of care and, quite frankly, a crisis of leadership at the John Dingell VA Medical Center in downtown Detroit. In response, Senator Stabenow and I called on the VA's Inspector General to conduct an independent investigation into that facility, which was launched shortly thereafter. Last summer, the Inspector General released its report, which included recommendations to remedy issues found at that facility. One of the recommendations related to removing conflicts of interest within the peer review process. And I've introduced legislation with Ranking Member Bozeman to the VA Peer Review Neutrality Act to act on the recommendations from that VA system. So my question for you, sir, is can you provide an update today on the Detroit VA's implementation of the recommendations contained within the Inspector General?
Yeah, thanks so much. I just talked to our VISN director this morning. She just happened to have her monthly update with Chris Colley, the VAMC director in Detroit yesterday. Importantly, on your question, recommendations 1, 2, and 8 are still open. 1 and 2 really relate to oversight of the surgery department and data collection in there. The next in that department, the next meeting with the IG is on the 10th of June. I hope that we can close those out or get closer to closing those out by then. Recommendation 8 relates to the demand from the IG that we get a permanent executive leadership team in place. So that's, and he has, I think, a numeric goal or a time elapsed goal on that. So we just need time on that. So that's not yet closed, but I hope it will be because our permanent executive med center director, Chris Colley, is doing a really fine job. Importantly, they've reopened 30 inpatient beds in the hospital. Imagine in the middle of Detroit, we had 30 inpatient beds closed. Those are opened. Care as measured by relative value units, RVUs, unique visits, and clinical encounters are all up right now, this year over last. Again, an indication of the seriousness of that leadership team and the staff's interest in getting that group functioning, that team functioning again. And for the first time in anybody's history, they're also helping with caseload management with Saginaw, with Battle Creek, in a way that we have long expected them to, but they have not done. Similar to the way Ann Arbor helps manage case flow for veterans, functioning as the high-level facility that they should be. So nothing's permanent. Obviously, we have to stay on top of this, but those are indications, I think, that we're making progress.
Right. Well, thank you. Thank you for continuing to work on that. Thank you, Mr. Chair.
Thank you, Senator Hovind.
Thank you, Ranking Member. Secretary, thanks for being here. Thanks for your work on behalf of veterans. Very much appreciate it. I want to pick up on something that Senator Murkowski was talking about, but a little bit different twist on it. But again, about making sure that our great veterans have access to cemeteries and their families have access to cemeteries. And as you're aware, because we've talked about it, in Fargo now we've established a cemetery and just expanded it from 5 to 35 acres. And it was initiated under the Rural Cemetery Initiative. I think it was the first one established. But that was 5 acres. But to show the need, we were going through that so fast that recently we worked with VA and expanded that to 35 acres. So now the key is to really enhance the facilities. As Senator Murkowski discussed, that's a challenge funding-wise. So we're willing to step forward and actually fund and build a visitor center on the cemetery, and we're working to do that. We've worked very closely with Assistant Secretary Matt Quinn, who has really been good to work with. I want to commend him, but I understand he'll be leaving on May 23rd. Yeah. So first I want to really thank him and commend him for the great work he's done, but I want to impress how important it is that we have somebody in that slot who will continue this work with us on a project that is really fantastic for veterans, keeping in mind, it was interesting to listen to Senator Murkowski because the VA National Cemetery, that serves an area you're very familiar with, all of western Minnesota, your home country.
Bigger fish are.
Yeah, exactly, Great Lakes. Great area, but a lot of folks that need access. It's a long way for them to Minneapolis. All of North Dakota, because this is the only veteran cemetery, federal cemetery we have, and a lot of South Dakota because they have to go all the way to Spearfish, which is on the very western edge. So this is situated where it will serve a big population, and we're willing to step up and cover the whole cost, in essence, and then donate it. But we obviously have to work through the bureaucratic challenges that go with that. So I really need your commitment, particularly as we're losing Secretary
Quinn.
Right, and he's done such a great job, the
Yeah.
Assistant Secretary, I should say,
Yeah.
Matt Quinn. But the new replacement, we're going to need somebody that
Yeah.
will work with us.
Yeah.
And I need your commitment on that.
Yeah, well, first of all, let's not let this go to Quinn's head. I mean, he's fine. He's fine, but, you know.
Well, he's from Montana, so I mean, we got to be
Yeah.
a little. And I was going to
Exactly.
commend our leaders on the full VA Authorization Committee too. Both Senators Tester and Rand. They've been working with us very
Yeah.
closely on that.
Yeah. So you've got my commitment on this, and I've made that commitment in private, and I'm happy to make it again here in public. That
Yeah.
we're going to make this work, and I think we've demonstrated that through Matt's commitment on this. He's routinely out there meeting with your vets, meeting with local community leaders, and we'll stay on top of it. You got my commitment on that.
And you're right about the lakes. They are really awesome. That's some great, beautiful area. But
I'm going home in
you
2
know,
weeks.
you know that when I lay that out for you, because you come from
Yeah.
there, that the need is there, and
Yeah.
this is important.
Yeah.
So thank you for that commitment. The second thing I wanted to talk to you about is veterans' access to health care in non-VA long-term care facilities. One of the challenges is that because of the, if I get it right here, the Office of Federal Contract Compliance Programs, they don't have a permanent rule that allows these nursing homes to accept VA reimbursement without a separate exam, separate from CMS. Now, I think it was the PAC Act, we provided authorization for the VA to exempt these facilities from OFCCP separate compliance exams if they were meeting the CMS requirements for Medicare and Medicaid, because it just makes sense that they don't go through this duplicate study, which was keeping a huge number of them from accepting veterans on VA, coverage. So VA insurance payments, to cover their stay. Now, you put in place a 2-year rule. We really appreciate that. That takes us to 2025. But for TRICARE, you passed a rule that just exempts it. Okay? And we need something like that in order to get these nursing homes to change their policy and accept veterans that are on VA reimbursement rather than Medicare or Medicaid. And so it's a 2-year, but I would really encourage you to look, because you have the authority now. We passed that in law.
Yeah.
But it would require a permanent rule on your part to do it. You did it with TRICARE, but you can see why on a 2-year basis, a lot of them are reluctant to change their
Definitely.
policy because they could be right back to dual exams. And that might mean another elevator. That might mean all these different things,
Fair enough.
And so I'd ask you to take a look at that.
I'm on it.
Okay.
I got it.
And then the last one is one you and I talked about, particularly in rural America, access to mental health care. Telemedicine's helped, but boy, any and all initiatives you have to help getting access to mental health care for our vets is really important.
Yeah, well, this is, when we talk about strategic hiring and that continuing, notwithstanding our net zero growth on FTEs over, this year, strategic hiring, front of the line there is psychologists, mental health professionals, mental health social workers. So we'll continue to do that. Secondly, you've given us authorities and investments to increase cooperation with tribes and with local communities to make sure that we're investing in them as well. Thirdly, we are also investing, we now have 1,900 peer specialists in VA. These are basically, the way I see it as a kind of an Irish American person, they're based on the AA model where we basically have recovering vets helping other vets, earlier in their recovery. Vets helping vets, and us making those investments in them is a proven help on substance use disorder, a proven help on mental health care. So we're trying to go out every vector there. Big VA, partners on the ground, and then traditional manifestations of mental health care providers And those will remain our priority because our number one clinical priority is suicide prevention.
Right.
And we're going to stay on top of this until there's none.
Right. Thank you, Secretary. Appreciate it.
Thank you. Senator Heinrich.
First, I just want to thank Senator Hoeven for his comments on mental health in particular. That's an incredible challenge, and especially in big rural states like mine. Secretary, welcome back. It's always good to see you. I want to ask you about the partial claim payment program. And when that ended relatively abruptly, it was really destabilizing for a lot of veterans in New Mexico. Obviously, we're in a very different interest rate environment than we were at the beginning of the pandemic. What steps is the VA taking to ensure that folks impacted by that will be included in the servicer purchasing program that's been stood up?
Yeah. Well, so we're reaching out to veterans who our data shows are struggling. We're communicating also as aggressively as we can to veterans to make sure that they're aware that we are standing up a new support program when the current moratorium expires at the end of this month, end of May. And, you know, we think that, and by the way, as a general matter, we're tracking veteran performance on their VA-backed mortgages because we have a whole series of programs not even associated with what we call the VASP, which is what will roll out when the moratorium ends, that we want to make sure that vets can avail themselves of through our debt management center. Great. So we're trying to communicate to vets individually. We're trying to communicate more generally to vets. And the new VASP program, which we've kept the committee up to date on, and will develop the implementation targets more aggressively over the course of the next 4 weeks, will allow us to make sure that veterans struggling do not lose their homes and come up with a more manageable debt picture over time.
Great. I know Senator Collins raised the highly rural transportation grant. I was pleased to be able to work to include some additional funding for that in FY24. My understanding, because I wasn't here when she asked her question, is that you may have referenced a legislative proposal in that area.
Yeah.
Do you want to expound on?
Well, we'd like to, you know, it serves. I mean, you and I, you're the first person to have raised this with me, and that's what I said to Senator Collins when we talked about it privately recently. New Mexico and Maine are uniquely poorly positioned based on the definition of highly rural, as you know, fewer than 7 people per square mile. We would like to change that in statute.
Great.
Right, and we have some proposals on how we would do that.
Fantastic.
And then, you know, we would couple that with a commensurate increase in funding, because, you know, it's just, right now, we have too few counties who can participate.
And I'm certainly not going to speak for Senator Collins, but I suspect we would both look forward to working with you on that front.
Right.
You talked a little bit about substance use treatment or substance use disorders. One of the challenges we see in New Mexico is that folks who want to treat their substance use disorder are having real challenges getting access to the medications that they're prescribed by their doctors, particularly buprenorphine. And it's been like literally people can't get their prescriptions filled. There's a number of reasons for this because this is a highly tracked, these medications are highly tracked. But I'd love for you to look into that because we want to make sure that our vets who want to get treatment can get the medications that they're being prescribed.
It's a major priority for us to increase medically assisted treatment. And so if there's, let's definitely dig into it.
Yeah,
there's no reason a veteran who's struggling and wants to take those steps, let's make sure that we're there for them when they do it.
Yeah, we've had real challenges with some of the big chain pharmacies just stocking those medications. And we can expand on.
That's interesting.
We'll get together and expand on why that is.
Yeah.
But we're not going to make headway on this if we can't get folks the
Yeah,
treatment.
well, we're
they
really
deserve.
proud of our medically assisted treatment options, and so that should not be reliant on any of those big boxes. You know, the question is maybe there's a mail order pharmacy issue for us, but let me dig into that. You got my attention on this. If there's one vet who's struggling to get that, that's too many.
Look forward to working with you.
Yeah.
Thank you.
Thanks, Senator. Senator Fisher.
Thank you, Madam Chairman. Thank you, Mr. Secretary, for being here today. And I just want to start off with thank you for all the great work we're seeing the VA do in Nebraska, and especially over this last year.
Thanks.
Last year during this hearing, we talked about needing to invest in the cemetery grant program. We did, and the Grand Island Cemetery is now on its way. And in your most recent budget, I was pleased to see that a new medical center for Omaha is now number 2 on the skip list. So thank you for that. That medical center is nearly 75 years old, and obviously renovations aren't going to cut it anymore. So we're very excited to see that move ahead, and I look forward to working with you on that. I appreciated your comments in our conversation about the community care program, and I do remain concerned about the future of that program. We have over 40% of Nebraska veterans, they live in rural areas, and many are located hours from the nearest VA facility, so that community care program is really vital for those people. In recent months, I've heard some of my colleagues call for tightening or even scaling back on that community care program. Of course, I want the VA to work on improving the appointment wait times, but that doesn't change the reality that we face in rural areas and sparsely populated areas. So does the VA have any plans to modify the access standards for that care program, and can you commit to us today that rural veterans will maintain access to care through that community care program?
Yeah, you know, the statute is very clear, the Mission Act, that drive time standards will continue to be impactful for rural veterans. We have big parts of Nebraska, big parts of, you know, the one I keep pointing out is Vision 7, which is part of South Carolina, Alabama, Georgia, Mississippi. You know, fully 70% of veterans there are referral qualified by virtue of where they live alone. So because of drive time. So it is an important access opportunity for veterans in rural areas. It will continue to be. Some of the things we're thinking about is updating the access standards to reflect the fact that overwhelming amount of care in VA and in the private sector is offered through telehealth. So we think our access standards should reflect that. Ideally that we'd be able to get that done fairly quickly, but that would be through rulemaking and there'd be public comment.
Then we have issues with connectivity, though.
Yeah.
Broadband deployment, because a lot of these sparsely populated areas in my state, that's a big issue.
Definitely, and we're not gonna give a vet a pig in a poke and say, hey, you should get, you know, knowing that they don't have internet access, tell them to go get internet access. So we have no interest in that. That's probably the biggest change we're anticipating currently. But, you know, it's been 6 years now since the law was enacted. Since then, we not only had the Mission Act, but then we had the pandemic, and now we have the PACT Act. Any one of those things would be a seismic impact on VA. 3 of them in a row. I think I'm really proud of the way our team has managed them. But I think it's reasonable for us to take a step back over the course of this year and ask, what are the impacts of all those things? If we anticipate changes out of those, we'll come talk to you about it.
Okay. You know, as we talked about on our call, you have a tight budget.
Yeah.
Very tight budget. And given the ongoing implementation of the PACT Act, which I was very proud to support, I believe it's important for the VA to ensure that it has staff in place to meet the needs of access to assist veterans. And I know in Nebraska we added over 200 employees, new employees, this past year to VA facilities. But with the department's budget request, I think you're envisioning an overall reduction of approximately 10,000 healthcare workers. Can you talk about the department's plans on how it plans to reduce the workforce, and will the reductions be equally spread across the VISNs and the VA facilities?
Yeah, so thanks so much. You know, we envisioned at the end of 2025, so that's September 2025, to be at about 10,000 fewer FTE. When all is said and done, frankly, that's, if you measure traditional attrition at VA, that's not much different than traditional attrition. However, because retention is so high, because you've been so generous to us for various pay enhancements, we have historically high retention, historically low quit rates. As a result, it might be a little tougher. We are not going to make those decisions from headquarters. These are going to be decisions made by our VISN leaders. This year is going to be a year of, as we're calling it, strategic hiring, where we need people. A good example is recently in Texas, San Antonio has been looking for GI experts, one of the most limited capabilities in healthcare in the United States right now. They finally found two, but they hired them both, right? So we'll continue our strategic hiring, but those are going to be VISN-based and facility-based decisions, not me making those decisions from here as a politico or as a bureaucrat. That's not good for veterans. And we'll track this month by month. We're doing this on FTE. We're doing it on dollars spent. And we'll talk this through with your teams so that they can follow along with us and watch that. And my guess is, I think one of our great strengths is our facility leadership having the kind of relationship that Omaha does with you, with their delegations. And so my guess is this is going to be a very public, very well-debated effort, and that's the way it should be.
Good. Good to hear.
Yeah.
Thank you, sir.
Thank you.
Thank you, Senator Fisher.
No, I don't have any more questions, but I do want to welcome you to this subcommittee. I had the opportunity of doing that yesterday in Milcon, part of the subcommittee, but I know you're going to make a tremendous difference. Senator Murray did a great job, but I've enjoyed working with you on veterans and the issues in the past, and we appreciate you. We're both blessed with excellent staffs, not good staffs, but excellent staffs that make us look better than we are.
It's the secret to success.
And then again, thank you, Mr. Secretary, so much. We appreciate you and your staff that really are working hard for veterans.
Thank you. I agree with what you said about your staffs, by the way.
That was wise of you.
Thank you so much, Senator. Secretary, thank you so much for being here today.
Thank you.
And for the work that you're doing on behalf of veterans all across our country.
Thank you very much, Madam Chair.
We're very lucky to have a subcommittee full of senators who care very deeply about veterans and the veterans who've served our country so well. So I'm excited to continue the bipartisan tradition of this subcommittee. That will conclude our hearing today. I'd like to say again, thank you to the Secretary and our colleagues for participating in today's hearing. I look forward to working together on this year's appropriations bill to ensure that we're providing veterans and their families with the benefits and care and support that they need. Finally, I will keep the hearing record open for 1 week. Committee members who'd like to submit written questions for the record should do so by 5 p.m. on Thursday, May 9th. We appreciate the department responding to those questions in a reasonable period of time. And with that, we stand adjourned.
Thank you.
Very good.
Thank you.